Okay, good morning, everybody. My name is Eric Yen, Director of Marketing for Shield Healthcare, and welcome to our webinar titled Identifying Pressure Ulcers, Assessment and Staging. Your presenter today is Nancy Morgan. Attendees will be in a listen-only mode. If you have a question for Nancy, please type it on the question box to the right-hand side of your screen. There's also a handout that you can download. At the end of the webinar, we will show you how to receive CE credits. You guys are all qualified for one CE credit, and again, we'll show you how to do that at the end of the webinar. At this time, I'd like to present Nancy Morgan. Nancy Morgan is the founding partner for the Wound Care Education Institute. She's been an RN for more than 20 years and board certified in wound, ostomy, and diabetic wounds. Nancy is a nursing entrepreneur with an MBA. She is a dynamic public speaker and international presenter who still conducts much of the hands-on training and wound care education for WCEI. Her motivational teaching style has inspired healthcare professionals across the nation. It was Nancy's entrepreneurial spirit that led her to co-create the Wound Care Education Institute. At this time, I'd like to pass the presentation over to Nancy. Nancy.
All right, Eric. Well, hey, thank you so much. I'm so happy to be here. Thank you, Shield Healthcare, for coordinating this event. I mean, we have blown record volume of people. There are hundreds of people on the line today, so thanks so much for coming out today. Some of you I know because I was watching the chat line, but then there's also a lot of new names that I saw that I don't know. So I just want to kind of let you know what my day job is, if I can. What I do, my day job is I do wound care certification courses across the country. They're a week long. You spend 4 days with us in classroom, and those that want to get board certified will sit for the National WCC exam. When you pass, you get 3 letters behind your name. That's what I've got on my shirt, WCC. And right now, by the end of the year, we're over 19,000 that are certified in the country in wound care. And that includes physicians, nurses that are LVNs, RNs, NPs, physical therapists, and also occupational therapists. So that's my day job. This is my fun job, talking to you guys from my office and doing this 1-hour webinar. So let's go ahead and get started. Going to change the slide here. Have you ever been stumped like this? I mean, I have to admit I have. You know, sometimes we look at a wound and we're like, what is this? Is this a DTI, or is this a stage 2, or is it a stage 3? Or maybe it's not even a pressure ulcer. Maybe it's a diabetic foot ulcer. So today I'm going to focus on giving you some detective tips that you can look for in the field to distinguish if it's diabetic, arterial, venous, pressure, maybe it's incontinence-associated breakdown, but we're going to go through all of that today to help navigate through some of this. So we're going to use a systematic diagnostic method, okay? That's kind of the key, and that just pretty much means kind of gathering all the data, doing an assessment. An assessment is key to everything. It's your foundation to everything. That's what's going to make your care plans. So we have to do a complete, 100% complete comprehensive wound assessment. So you see the bullseye on my screen? Well, that's jumping inside those wounds, inside the center, looking at the tissue types, the structures, and then looking at the edges of the wound. And then we have to include the peri-wound assessment. Peri means around, so it's around the wound, peri-wound. And we have to include a minimum of 4 centimeters because the surrounding tissue kind of tells us what's happening to the wound itself. So we're going to do all that. And when we do an assessment, it's not just looking, and a lot of clinicians may forget. You know, these are really great tools, and that's your fingertips. I want you to get in there and I want you to palpate the tissue because you can pick up a lot of imperfections just by taking the time and palpating. I also want you to listen to wounds. Well, Nancy, wounds don't talk. How can I listen? What am I listening to? Okay, if you ever listen carefully, there are some wounds that you'll see in your practice when you're palpating. You may hear some cracking or popping. Sometimes the tissue will do that, and that means that there is toxic gas buildup. And that's a medical emergency. So we do have to palpate and kind of listen too. Also, listening applies to talking to the patient, listening to them, listening to the caregivers that take care of them, or the family members. And then As much as some of us don't like to smell wounds, we really do need to smell the wound. So we want to clean that wound real good, and then we want to take a whiff, because that kind of tells us what's going on the bacterial side of things. So, okay, we got the comprehensive wound assessment down. Well, you know, when you look at this picture, right now, just quick look, it looks like it might have been a pressure ulcer. But if we pull back on our vision, now that round ulcer, now we notice it's on the bottom of this person's foot. We also can see the callus formation, which we call hyperkeratotic tissue. We also see that. So getting in all those clues tells us, you know what? That's a diabetic foot ulcer. That's not a pressure ulcer. So that's why assessment is so important, taking the time and gathering all this information. So let's just kind of start with pressure ulcers, okay? Pressure ulcers, you know, are typically found on the bony prominences, as we probably know. And it's a result of pressure, shear, and also with some shearing forces that's added onto it. Now this is kind of what it looks like, the cut section of the skin. So here we go. The skin is compressed. And when the skin is compressed because of pressure, maybe the patient's immobile and they're laying in one position for an extended period of time, well, that chokes off the blood supply. And when you don't have blood supply, what happens to the tissue? The tissue is going to start to die. And that's when we get into, you know, some very deep ulcers and, you know, at our stage 3, 4 level. So we don't want that to happen. But, you know, a pressure ulcer can start in as little as 2 hours. 2 hours. So we've got to kind of keep that in mind when we're assessing the skin. Now, friction, I'll be honest with you, when I got out of nursing school, I had no clue the difference between friction and shearing. So here's just the skinny on friction. Friction is superficial. It's just two surfaces rubbing up against each other. That's all it is. So for instance, maybe you're moving your patient to the head of the bed and you have the draw sheet, but you accidentally allowed the elbow to scrape across the surface of the bed and the epidermis is missing. Well, that would be an example of friction. At this point, the epidermis is gone. We have destruction in the dermis, but we're not through the dermis at this point. So we're pink, we're partial, and we're painful. So that's friction. Shearing, totally different situation. You know, our patients get shearing injuries usually one of two ways, if not both. So see the picture on the top. Okay, you see this gentleman, the head of the bed is elevated very high, actually. And what happens is he will slide down. And then what do? We move him back up, and then he slides down. Well, you're probably sitting in a chair right now, so you could do this exercise with me. We put our patient in the chair, and they're sitting nice, and we got them bolstered, they're positioned correctly, but we check on them in an hour. And what happens when we check on them in an hour? Well, they slouch down, right? Okay. Well, when you slouch down like that, what's happening to your skin? Your skin is getting caught up in the chair. You know, your butt cheeks are going one way, and your bones are going down towards gravity. So you got skin going one way, bones going the other way, and it's going on all day long. Well, shearing is going to hit you at bone and muscle level. These types of injuries to the skin are very, very deep, unlike friction. Friction was pink, partial, painful, right? Very superficial. This one is deep, and it can cause undermining and tunneling, so we want to keep that in mind. Okay, so let's take a look at a patient that has pressure ulcers. What do they typically look like? Okay, well, these are found on the bony prominence, as we see on the picture. And it kind of looks like a crater. It's either circular or oval, usually, if it's just solely caused by pressure. It could be partial or full thickness. And if you take a look at this, the margins are very even, they're defined, you kind of know where they start, where they end. It has that ruddy red color that is typical with the wound bed color. There is a staging system that hooks up with pressure ulcers, and it's created by the National Pressure Ulcer Advisory Panel. Well, they updated it back in 2007, so it's the same definitions. And what they did was pretty much make 6 main stages. And I'm going to walk you through it. Now, I know it's been around for a while, so I'm not going to sit here and recreate the wheel. But what I am going to do, because I know many of you are teachers, and you're going to go out there and teach other coworkers, so I'm going to walk you through the staging system that is easy to teach and easy to get. Because the number one question I get at the Institute is people are asking me about, staging questions. So I want to kind of walk you through this. a little different. Let's start with unstageable. When you see, a wound that's like this, now this is only going to apply to full thickness wounds when we have eschar or slough that's in our way. And so we can't clearly, do you agree? We can't clearly put a stage on it because we have this necrotic tissue in our way. So we've got to put some product on it, get this thing lifted up, offload it, and then maybe we go back in 7 days and maybe we can clearly put a stage by it. For right now, the way it looks, we're going to call it unstageable. Now, stage 1, there's 3 key things to remember on stage 1. You're going to get it right all the time. It has to be intact skin. That's what we see on the picture. Intact skin, no openings to the skin. And then 2 key things behind that. It has to be non-blanchable redness. So non-blanchable means, see that red site on the heel? You put your finger in the middle of it and you count to 3. 1, 2, 3. You remove your finger and it's still red. That's non-blanchable, meaning that the color didn't change. Well, let's try it on the back of our hand. You could do this with me if you'd like. I press my finger in my tissue, 1, 2, 3. I remove it, goes to pale, then goes back to my normal skin color. Well, then this is blanchable, right? Because the skin, the color changed. Thank goodness I don't have a stage 1. Well, if it's still red, but it's blanchable, we just call it reddened skin. However, if we do the blanching test and this is non-blanchable, no color change, that's a stage 1. So just to rehearse again, summary, intact, non-blanchable, redness. Those are the 3 key things. The rest of the definition you guys have in your outline. It's pretty similar to DTI. The adjacent tissue might be warmer or cooler when you're comparing the site to the adjacent tissue. It might be soft. It might be firm. That's very similar to DTI. On dark skin, absolutely got to palpate that tissue because with dark skin, we don't catch stage 1. I'll be honest with you. A lot of times we don't catch these until they open up, and we want to catch it sooner on dark skin. So we want to have good lighting so we can examine the skin and definitely palpate. Stage 2s. I already talked to you about the 3 Ps when we talked about friction. Stage 2s are pink, partial, painful. That is the key to remember in order to get these right. Let me tell you where we're at. Epidermis is missing. You have destruction in the dermis, but you're not through it right now. So you're pink, you're partial, and you're painful. Now, I'm going to throw 2 things to add on to this, okay? See that blister on the heel? Okay, so when you see blisters that are caused by pressure, I want you to look inside the fluid. So let's look inside the fluid. Okay, if it's clear fluid, serum filled, then okay, we'd call it a stage 2. But if we see dark, dark fluid, sometimes we'll see a speck of brown in there. Well, that's blood. And if it's blood filled, we call it a DTI. But if it's clear, we call it a stage 2. And then one more thing on my slide, notice the last bullet. In the definition of a stage 2, it states that there's no slough. So in case you still see clinicians, and they're out there just because they just don't know and they're not in the loop. So when you tell them, hey, listen, you know what? When they're documenting stage 2s, 100% yellow slough, just say, you know what, that's kind of wrong because back, on the definitions, it says no slough in a stage 2. So this is where we can get our coworkers kind of up to speed too. They did put that in the definition back in 2007. It's always going to be pink, partial, painful. That's the only color you're ever going to see in stage 2s. Stage 3. All right. This is going to apply to full thickness because this is where we're at. Peel off the epidermis. Peel off the dermis. Now you're in the subcutaneous tissue area, and that's where you're at. You're not any further down. You're not any further higher. You are hanging out in the sub-Q zone, okay? So I want you to think about it. I'm in the sub-Q, and it starts to die. What's going to happen? It's going to turn to slough, okay, which is slough is moist, kind of a mushy-gushy kind of a tissue. Now, don't document mushy-gushy. You get me, right? I'm just kind of explaining what it's kind of like. And then if you let the slough dry up, it can turn into eschar. Okay, so we could see slough or eschar in this stage. Because we're in the sub-Q, we could have tunneling or undermining. So we can maybe see those in this stage as well. Here's the key thing that I want you to just really bring to your attention because this is game-changing. Notice my last bullet. So when it says no bone or tendon visible or palpable. Here we go. It's our fingertips again is the key to this. So here we have these 2 wounds that are on the screen. They're full thickness wounds. I know they're full thickness because we see slough in them and we also see granulation. So we know we're minimally in the sub-Q. I don't see muscle, bone, or tendon. I'm going to get my gloved hands on and I'm going to palpate that wound bed. If I'm only palpating solid tissue, okay, fine. We'll call it a stage 3. But if for some reason I feel bone or I feel muscle, trump that to a stage 4. Big game changing. So what I've seen is a lot of people on admission, they see these full thickness wounds. They didn't palpate the wound bed. They're calling them a stage 3. And then patients in your hospital or whatever, or home care agency for a couple of days, and all of a sudden a bone's sticking out. Now, what is it? It's a stage 4. You had to upstage, which red flags your agency and facility. So make sure you're having your staff take that extra step, palpate the wound beds of all these full thickness wounds to just double check that they're not stage 4s, okay? And in the definition, that's what's backing you up. Stage 4, we can see muscle bone tendon, we can feel muscle bone tendon, okay? This one's pretty much easy. The rest of the definition pretty much matches the definition of stage 3. You could have slough or eschar. You could have undermining or tunneling. That's kind of all the same. But this one, we definitely can see and palpate that, palpate that bone muscle tendon. Hopefully that helps walking through it that way. I left DTI to the last. Some folks call it SDTI, some call it just straight up DTI, but I'm just going to call it DTI. And in order to be a DTI, this is caused by pressure. It's got to have 3 key things. Intact skin, okay, that's what we see on the screen, intact, no breaks in the skin. And the color that we're looking for is purple or maroon. Not red, notice that, didn't say red like I did with stage 1. Purple or maroon is what I'm looking for. And then if we have a blister that's caused by pressure, we need to look inside that fluid. Is it dark? Well, if it's dark, it's blood, so we're going to call it a DTI because blood-filled blisters are considered DTI. I want you to remember, DTI, the D in the DTI stands for deep. These things can be very deep once they open. Okay. Oh, one more comment, just backing up. I get a lot of calls. I have a DTI. Let's talk about the first picture. And inside the middle of it, it opened. Now, is that an open DTI, Nan? Here's the scoop on this. No, because there is no such thing as an open DTI. That's not meeting definition. Definition says it must be intact. So here we go. If this DTI opens, I want you to look inside the opening and see if you can identify tissue or structures or palpate any structures, okay? If you can't, and a lot of times when these open, they're so dark, they're purple or maroon, 9 out of 10 times, I'll be honest with you, you're not going to know what you're seeing. So you could call it unstageable for right now. And then get some product on it, offload the site, go back in 7 days or when you reassess to see perhaps at that point, maybe you can put a stage by it. That's how you roll with things like that. Hopefully that helps. Okay. Now, there are areas that are a breakdown that we'll see on our patients, and it's on mucosal membranes, like inside the mouth, inside the nose, and these we do not stage whatsoever. What they want us to call it is just a straight-up mucosal pressure ulcer. We wouldn't even call this a partial or full thickness wound. Why? Well, because, there's different structures in the mouth on mucosal tissue. It's not the epidermis, dermis, sub-Q, muscle bone. Doesn't have that, so we can't accurately stage it, okay, with the staging system. So we're just going to label mucosal pressure ulcer straight up. Well, when this came out, I have to admit, I had to think, okay, now, where in the body is all the mucous membranes? Hey, it's been a while since I was in A&P in college, so I'm like, okay, well, more I thought about it, there's a lot of areas that I have to put on my radar. So inside the nose, the urinary tract, if you have a patient with an ostomy, the stoma itself, that's considered mucosal. So if you have breakdown there, that would be mucosal pressure ulcer. Vaginal canal, the tongue, the head of the penis, the foreskin of the penis. So that little list is very helpful to kind of guide you. That way you're not staging inappropriately. If it's on mucous membranes, we're going to call it mucosal pressure ulcer straight up. Here's just Here's just like another list of why we see these in healthcare is because some of the medical devices that we use on the patients, Foley catheter tubes, bite blocks, endotracheal tubes, oxygen tubing, fecal incontinence, contaminant devices. So keep that in mind. Here's another thing I see in the field. This patient clearly is incontinent. Agreed? Okay, because of the location, the way the borders look, and so on. Okay. A lot of people stage this, and they're staging it unnecessarily. So let's just kind of look at some slides so we get this right. This is related to moisture, okay? Patient's incontinent. It should not be confused whatsoever with a pressure ulcer. I know you've seen patients in this condition. I mean, it's just, oof. I mean, you can just imagine how painful this is. Well, when we see sites like this caused by moisture, we can call it lots of different names. It just depends on, you know, what your facility calls it. They could call it a straight-up incontinence-associated dermatitis, IAD. They may call it moisture-related skin breakdown. Some may call it perineal dermatitis. But that's what it is. This is definitely caused by incontinence. And right now, it's pink, it's partial, and it's painful. So it has the 3 Ps that we talked about earlier. So where is this located? Well, it's located over fatty tissue of the, you know, the buttocks, the perineum. We'll see this in the groin, inner thigh, the inner thigh. It could be patchy. It could be consolidated. Here you go. Here's some more pictures. Here's the key, though. In order to call it an IAD, you have to have moisture that's present in order to call it IAD. So this is definitely partial thickness. It's superficial right now. There is no necrosis, right? So there's no slough, there's no eschar at this point. So if there isn't, we call it an IAD. The margins could be diffuse or irregular. So that could vary on these sites. But if for some reason you have IAD and it's hanging around at your agency or building or whatever too long, and it gets to a full thickness state, which you see on my screen right now, where you see slough or eschar or granulation tissue, you know, it's telling you that it's in a full thickness state. This is the line that is now drawn to once you jump over in a full thickness state, you got to stage it. We have to stage it. But it wasn't caused by pressure. Yeah, but the way they look at it, it sounds like, you know, what they see is, hey, you had IAD, it was hanging around in your building, you didn't do anything with it, and now it got worse. Now it's full thickness, and that's because we have ischemic response. Well, no blood flow causes it to go into a full thickness, and that's how they view it. So in this case, we'd have to stage it. So these would be high stages. It's going to be unstageable, stage 3, stage 4, depending on what the site looks like. So when you see IAD, this is where you get good product, not cheap product, good product on that site. Get that patient offloaded off that site. Get on it right away because, you know, you are only a few cell layers away from hitting full thickness. And remember, we talked about pressure ulcer can start in as little as 2 hours. The time is clicking when it comes to this. Here's another situation that we might see on our patient. You guys want to try to pronounce that word? Go ahead and try. Oh, I heard you guys. I think you need a little help. I know it's a mouthful. It's what I call it is Intertrigo. It's tough. That's why I kind of broke out the word on the slide. It's intertriginous. And if you can't remember how to say it, just say it fast in front of your friends. They'll just think you're a rock star. It's okay, just say it fast. Or Intertrigo is pretty easy too. Anyway, it's short. We shorten this up and call it ITD. And what causes this is, okay, we are under the breast folds, okay, and we have skin-on-skin friction that's going on, and it's trapping perspiration, and the skin is breaking down. So we call it ITD. This can be found anywhere. Any of the folds, the intergluteal cleft, it could be under the pannus. Pannus is a fancy name for, you know, how the gut hangs over your belt line. Some people call it an apron. That's layman's terms, but that's what the pannus is. So underneath there, we'd see that. Under the breast as the picture, in the groin creases. Here we go. And they also say that the distribution is very mirrored image. So when you split the folds, like you see on the picture, they split the folds, the top fold matches the bottom fold. So, I mean, they're just like an exact pattern. That's another sign to say, oh, that's ITD. That's what's going on with this. And it's that linear shape, which is kind of a line, has like a line shape. Now, these are pink partial painful. They might have a little oozing going on, maceration. There could even be some crusting because there's moisture, that can kind of cake up in there. And if people put products, some people put powder. Not that that's always the best thing to do, but sometimes they do and it get all cakey in there. So that's kind of what that would look like. Here's a closer up one of ITD. This could be very painful to the patient, itchy, burning, irritating. It could cast some kind of odor. And believe it or not, you can have ITD can coexist with IAD. I know, all these abbreviations in healthcare, right? But the two can coexist together, so keep that in mind. Now, here we have, this is yeast, okay? And I'm sure you've seen this on your patients. Overgrowth of yeast, maybe they're on a lot of antibiotics. Yeast will hang out in warm, moist areas, as you see. They would be found in the body folds as well, underneath the arms, in the groin. It could be patchy or consolidated. But notice the key classic sign is, see these just red bumps that you see outside this big patch? A lot of times we'll get those satellite lesions, and nobody knows what it is. They put some moisture on it, and then it just like, it flares up. It's angry. It's red. It starts extending the borders. That's another sign that, hey, you probably have some yeast kicking, going on. Also, yeast you can smell. Not always, but, you can smell that yeasty smell. Here's some different other pictures. So, it would be a papular kind of look, lesion, or it could even be a pustule type look. Pustule, just a fancy name for like a whitehead. But this is right now just partial thickness, pink partial painful. Could have some crusting, scaling. It could have this cheesy white exudate that would be throwing off, and again, you'd probably smell that. Notice the borders. The borders are kind of diffuse, which means scattered about. It's not necessarily defined edges. But on this, your patient's, itchy, very irritating, burning. That would be another key. That, hey, this is definitely yeast. Let's treat it. And with yeast, once you pick up on it, you get antifungal cream to the site, and you'll see a difference in like 24 hours. It'll be the borders of the wound will go less. It'll shrink down. It'll be less red, less angry looking, and then you're on the right track. I put in bruises because I get a lot of questions in the field, and people tell me, was that a bruise? I think it's just a bruise. It's not a DTI. Well, bruises and DTI are really two separate entities. I'm just going to kind of walk you through this for a moment. Let's start by a bruise. That's a bruise, okay? This is on someone's leg, and a bruise is called, well, sometimes they call it contusion. But a bruise is like blunt force trauma. Something hit that site so hard, it busted the vessels, okay? And then you've got blood underneath the skin. Now, a bruise, and I'm sure you've had a bruise before, a bruise will take care of itself in a matter of a few weeks. Doesn't need a lot of intervention, okay? We just know it's there, and it's an obvious site. That's what a bruise is. Now, I thought this was cool, and I would remember this that way in case you're in front of your friends. You sound like a rock star. The bruise, as it ages, follows the banana timeline. Yeah, banana timeline. Let me walk you through that. Say you need bananas. You go out to the grocery store. Which ones do you buy? Do you buy the brown ones? No, you probably buy the green ones because you want them to hang out on your counter for a while, right? On your little banana hook, if you have one of those. Well, anyway, so that's kind of what a bruise does. Yeah, it kind of has this green look, then it goes to yellow, then it goes to brown, and then eventually fades away. So it follows the banana timeline. Now, what's that going to do for you? on a detective timeline. Well, hey, if you're doing skin checks and all of a sudden you see a bruise that is brown, well, you know that's been around for a while, right? Because, hey, if it just happened, it tend to have more green tones to it. Banana timeline. Cute monkey, huh? Okay. All right. Well, here's another thing, some other key things on bruises. It's intact. There's no openings in the skin at all whatsoever. And the tissue can be swollen. I mean, it could really hurt, like that toe. You know it. Ooh, you know, they jam that toe in a door, and that toe got pinched. You know that's hurtful. So that's kind of what a bruise is. Here's something else I just thought I'd add today. This is purpura, and this is red to purple lesions that you'll see on the patient's skin. And all this is, it's kind of like a leakage of blood up under the skin. You could even see in the mucous membranes. These could be flat, or you could maybe palpate them. That's going to kind of vary across the board, but that's what that is. Here is petechiae. Now, petechiae, see how small pinpoint those are? I mean, these measure less than 3 mm, okay, in size. They're just like little pin spots. Okay, now, these don't blanch. You can't palpate them because they're flat. I mean, they're pretty much flat discoloration. We'll see this in patients that have an abnormal platelet function, inflammatory skin diseases. Now, when you document these, you need to count every single little red pinpoint lesion. No, I'm just joking. I'm just joking. I know some of you kind of probably dropped your heads. Huh? What did she say? No, we don't have enough time in the day to be doing that. What we would do is measure with our measuring ruler the affected area of where these are located. Okay, here is something called ecchymosis. Yeah, ecchymosis. Now, these are going to measure bigger than petechiae. This is larger than 5 mm. Now, this is caused by, blood disorders and complications, but this has nothing to do whatsoever with trauma. I'll be honest with you. In my early days, before I knew this, I just thought, I see a patient like this, I'd be like, oh, boy, who's grabbing onto them too hard? I thought they were all bruises, and it's not. No, it's not at all. So this can easily be mistaken, so you kind of want to keep that on your radar. This is not the same as a bruise or a contusion. Notice the edges, they're irregular, okay? They're not perfectly round or anything. They're all irregular. We can also see these on the mucous membranes, and the color is going to be blue to purple in color. Hematoma, totally something different than what we've talked about. This is, you've got a leakage of blood from broken blood vessels, and it's up underneath the skin. Now, this is now trapped, okay? And so what this can do is kind of swell up, which you can see on that left extremity. This is not another name for a bruise or a contusion, okay? This is a different situation. Now, you could have this embedded within a bruise as a palpable mass, but this is definitely a hematoma, and these can be huge in size. Now let's just take it back to DTI. And I know we just went over this, but now I just kind of want to, let's hit some key things. So that way we get DTI straight on all the time and not confuse it with ecchymosis and petechiae and purpura and so on. So DTI, the 3 key things was intact, purple or maroon, right, or blood-filled blister. Those are the key things. Now, in order to have a DTI, you have to have immobility. So there has to be some kind of pressure to the site for a certain duration of time. And what happens is it starts on the site and then it deteriorates rapidly. And when you touch the site, it's going to be boggy. Bruises aren't necessarily boggy if you think about it and compare that with against that. DTI is non-blanchable tissue. Okay, it's purple or maroon in color. This might be painful or it might not. That could vary. Now, I have a lot of clinicians ask me, now how long would it take to get a DTI to move it to a mature site, full thickness site? Well, it's about 15 days. Now, there are times, and I don't know if this has ever happened to you, so you get a patient, let's say it's day 3 of admission, and all of a sudden this patient breaks down, even though you gave them a good bed, you offloaded the site, you did everything you could, and they broke down. Day 3 of admission. Well, there's a 7-day principle that I just want to introduce to you. And in the references on my outline, it's the forensic study, and it was a forensic study that was done focusing on the skin. So let's just say, all right, I see Mr. Jones, here's the wound, okay? When I see clear demarcation lines, demarcation is a fancy word for I know where the good skin starts and the bad skin ends, okay? I kind of know exactly where that demarcation line is. I need to stop, I need to go back to the calendar for a moment, and I need to count back 7 days. If I count back 7 days, 7 days ago is where the damage occurred. What I'm seeing is the result of the damage that occurred. So what does that mean? You know how everyone finger points to each other? Oh, that happened in long-term care. Oh, no, that happened in home care or hospital. This is how you're really going to know. Once you see the demarcation line, count back 7 days. Wherever that patient was 7 days ago, that's where the problem happened. That's where the damage occurred. Now let me walk you through as this breaks down. Here's an example of the same site, but we're at day 9 through 11. And the article mentions skin slippage. We don't necessarily say slippage, but the article did. But, skin is sloughing off, okay? We're losing skin at this point, anywhere from 9 to 11 days. And then we go to the 14th to the 15th day. This is where that site, we will now see a formed, mature, brown or black eschar. So it's about a 15-day turnaround from the start of it and how it progresses. So an SDTI can get to an unstageable situation in 15 days. Now here's the scoop. If you are unsure that it's a DTI or a bruise, you're not sure, okay? This is what I would do to protect yourself. Document that it's a DTI. Just document that's a DTI. You can always revise this later, but document that's a DTI, offload it. If you've got to put some product on it, put some product on it, and then go reassess. Okay, so I added some vascular ulcers here towards the end of our presentation because I see folks staging vascular and diabetic ulcers, and they're staging unnecessarily, okay? So let's just take a look. We'll start with arterial ulcers. Arterial ulcers are typically found ankle down, okay? So A for ankle, arterial starts with an A. That's how I keep it straight in my head, AA, okay? So ankle down, this is what we would see. It's dry, flaky, scaly. These ulcers are found on the tips of the toes and between the toes, over the phalange heads, around the outside ankle bone, which is around the lateral malleolus, and then also areas on the foot that are subject to rubbing footwear. It's dry, flaky, scaly. What happens here is not enough blood flow is going down there, and that's the furthest part from the heart, right? So if you don't have much blood flow, impaired blood flow or no blood flow, this is what you would see. There's not even hair. You don't even see hair growth because not enough blood to support hair growth. Okay. So when you look at these ulcers, they are very defined, and the books say that it kind of has that punched out kind of look. These can be definitely shallow. It start out shallow, but it can go to deep. These could be very deep ulcers, but very pale wound bed. Why is it pale? Well, there's not much blood flow, right? So we wouldn't necessarily see a beefy red type wound bed with this. No, it'll be pale pink. A lot of times we'll get eschar or slough on these sites. Drainage level, not much drainage, okay? Again, not much blood flow, so not much drainage with these. Here's another one, okay? So we have it in the classic sign, ankle down, lateral malleolus on the top of the foot. So some other key things we would key in on, hairless. It could have cyanosis when you touch the site. It could be, cool, cold. When you do an ABI, the associated findings on the ABI would be less than or equal to 0.9. You would have diminished pulses when you're checking pulses. So those are just some different key things to look for. With venous leg ulcers, totally different. See where I painted the legs where it's green? That's where they hang out. It's mid-calf to ankle. And it's also located a lot of times medial, so medial lower leg, ankle. These are irregular in shape, and as you can see here, these tend to have a lot of drainage, so very wet type wounds. So we would use products that will absorb exudate. Here we go. See, notice that they're located medial. Okay. The wound bed is ruddy red. Could have slough or eschar. That could vary, but definitely heavy exudate. You can also have some hemosiderin staining. Do you see the leg there, how it has like a little shadow, mid-calf to ankle? Little brownish shadow. That's hemosiderin staining. That's what that is. Mm-hmm. Here's another one. Okay, so it's medial, located there at the ankle. Have some edema. They can get firm edema. These can get quite large. Mm-hmm. A lot of times when these patients have venous leg ulcers, there's other scars that you can see when you're examining the limb to see that they've had that historically before too in these other areas. These are the patients that, once you heal the wound, we still have to continue to support this patient throughout their life. They need to be in compression stockings for the rest of their life so they don't get another one of these. Okay, this one here is diabetic neuropathic ulcers, and I painted the feet on where these hang out. These typically are found on the plantar aspect of the foot. The patient would have a diagnosis of diabetes, peripheral neuropathy, peripheral arterial disease, and these are located on on the metatarsal heads, okay, under the heel. Here's one on someone's foot. Notice the callus formation that's around there. This could be definitely a deep ulcer. Here's another one. The wound bed color can vary across the board, okay? But definitely we get this callus formation. We call it hyperkeratotic tissue or fibrotic tissue. Definitely define ulcers. Oh, wow, look at this one here. See, plantar aspect of the foot. We actually have some maceration on the callus formation, right? Mm-hmm. So we kind of need to address that. And there's a lot of times we'll see foot deformities in our diabetic patient population, and that's exactly what you see here. That patient's right foot has Charcot. It's Charcot foot, and that is, I'll just give you the skinny on that. What that is the patient is lacking sensation on their feet, and it just gets worse as their disease progresses. So what happens is patient could be walking about life, breaking bones on their feet, fracturing bones on their feet, but they don't feel it. Okay, so they continue to walk about life, and then the foot spreads out and looks like this, and that is called Charcot. If we can catch the patient when it just happens, we can fix that, and we do that through a total contact cast boot. But if this has been around for a while because the patient don't even know it, we find out months later, we really can't help them. We just got to, try to help offload that wound, and if they have a wound, and, kind of get them healed the best we can. So that is that. Sometimes they can get osteomyelitis. Foot deformity is just big hot button in this population. To determine if it's a pressure ulcer, I want you to gather the facts. Once the facts are all in, okay, this is when you can clearly make a good, sound judgment. Is it arterial? Is it venous? Is it IED? Is it ITD? Look at the location, the shape. Look at what the patient does during the day. Are they in a chair and they're slouched down in the chair, or the head of the bed elevated for an extended period of time? What is going on? Bring all those detective clues and put them together and see if you can find out the true etiology of what caused that wound to begin with. And then go from there. Now, I have this little nice cheat sheet that I have at the end of your outline. Feel free to share it with your friends, but this is just like a real quick and dirty way to one page to help you kind of look at all the detective clues on the left and kind of figure out what this wound type might be. So hopefully that will help you. And I have Eric popping in for because now it's time for some Q&A. So, Eric?
Great, thanks, Nancy. That was a great presentation. If you have a question for Nancy, please type it on the question box to the right-hand side of your screen. As we wait for questions, I encourage all the attendees to check out our community page at www.shieldhealthcare.com/community. We have a wound care section, and it talks about the various things that Nancy was talking about, and it actually has some handouts that you can print off on how to identify different pressure ulcer stages as well. So again, shieldhealthcare.com/community. Also, we'll show you how to get CE credits after this slide, but you can also go on the healthcare professional section on the community page if you missed any portion of this. So again, this webinar is being recorded, and if you miss anything, you can we'll post it on our community page as well. So there's a couple of questions about if we can hand out these slides, and unfortunately they are proprietary to WCEI, so we cannot hand out the slides, but again, this recording will be posted on the community page, so if you did miss anything, you can go back and listen to the recording. So, all right, let's go ahead and take some questions here. Hang on a second. Got tons of questions for you, Nancy. What if the wound has hardness on the side of the skin? Is that slough?
Oh. What if the wound has hardness? So when they're palpating hardness on the outside of the wound is what I'm assuming?
Yes.
That is an assessment finding called induration. So, and that is when the peri-wound tissue is raised up and it's quite firm when you palpate. So that would be called induration, which is one of the signs of potential infection. That would be the answer on that one.
Great, thank you. So the cheat sheet is not at the end of my outline. So if you go onto the right-hand side of your screen, there's a PDF that you can actually click on and it'll open up. So a question here, can you tell us the difference between cellulitis and venous ulcers?
Yeah. Venous ulcers is what we saw on the screen. Okay, they're located mid-calf to ankle, and it's caused by venous insufficiency. They would have that diagnosis. Cellulitis is an inflammatory process. It's infection, and so that will hit pretty suddenly. You would clearly know. And here's the thing: when you're looking at these wounds, if wounds are not behaving the way you think they should, and in this case, you could have a venous-like ulcer that got cellulitis. And that can move very quickly. So those are two different. But cellulitis, the itis, is the infection of that, the cell layers. That's what's going on with that, and they do need to be treated for that.
Great, thank you, Nancy. Can you tell us the difference between purpura and ecchymosis? Am I saying that right? Ecchymosis.
Pretty much your purpura and your ecchymosis would be based on the dimensions of the site.
Great. Can you tell us the difference between nystatin cream and nystatin powder? When would you use one versus the other?
Both of them are fine. Okay, we would definitely, of course, use this on yeast. It would just depend on where I'm putting it. And honestly, it's whatever I can get my hands on first. I tend to myself go for the cream because it kind of stays in that area. But I just as soon as you can get your hands on it, just get it on the site, and you'll see a big difference within 24 hours. The only time I might consider going powder is if the site's really, really weepy. So I'll go in powder so that way it can the powder can kind of help absorb some of that moisture. Mm-hmm. Great.
Thank you, Nancy. What products do you recommend to treat IAD so it doesn't deteriorate into a pressure ulcer?
Okay. Because your assessment skills are laser sharp, guys, once you find IAD, partial painful, I want you to reevaluate the bowel and bladder program. What's causing this? Is there something that we can do to divert the urine and stool away? Because that's what's causing this, usually. I'd also make sure that you get a nice, very nice moisture barrier. It can be zinc oxide based or it can be petroleum based. Those are designed to stay on the skin longer. And I always say this, just frost that area like a cake. And that way, if there is an incontinent episode, it'll spill right past that area and protect that skin. So I would go for zinc oxide or petroleum based if I'm dealing with product. Mm-hmm.
Great, thank you. Is it best to order both a venous and arterial Doppler when you have a non-healing wound on the lower extremities?
I'm glad you brought that up. There are new guidelines that came out the fall of 2014, and it takes us a while for us to get it at bedside, so that is actually what I've been doing on tour this year, is talking about the guidelines. Here's the scoop. Any lower extremity ulcer, you need to make sure you get an ABI done, minimally. Now, if you're in a hospital setting, the patient can go to diagnostics, get advanced studies. But if you're in home care, long-term care, you need to get, you can do an ABI if you're trained. And an ABI is like taking a blood pressure of a lower extremity. But so they want you to do it on every single lower extremity ulcer. They also want you to do it if you get an order for compression, someone wants you to compress that leg with some kind of ACE bandage or a multi-layer bandage, you got to make sure you get that ABI in place to see if you can even safely apply. Sometimes these patients don't have enough blood flow, and then you compress that limb, we could lose the limb. So an ABI is really going to protect themselves. So make sure y'all buy Dopplers, at least have one at every agency and one at every nursing home. Acute care, y'all have your own diagnostic department. So, yeah. Great.
Thank you, Nancy. What products would you apply to an area with a DTI?
There is nothing open and active that's there. So the main thing with the DTI is you want to offload. Now, there are some folks that want to put product on. Some folks want to put like maybe a skin barrier on the site that's intact, okay, because it is intact. That's okay, but the main thing is make sure you offload it. Take away the cause. You know the cause is pressure. Remove the cause. Keep an eye on it. If you want to put a dry dressing on it so it doesn't have any friction to whatever the linens and so on, you can certainly put a dry dressing over it. Those would be a couple options, but the main thing is offload on this.
Great, thank you. With IAD progression to full thickness ulcer, could this not also be described as friction damage instead of pressure, since the damage is located on the fleshy part of the buttocks and not over the bone?
No. If you have IED, partial painful, and it goes and converts to a full thickness, it's a pressure ulcer no matter where it's located. I mean, IED is going to be located somewhere where there's moisture. You've got to have moisture in order to have IED. So if it converts to full thickness, it's pressure ulcer, no matter where it's located.
Great. Thank you, Nancy. There's so many questions, and I apologize if we don't get to all of them, but these are all great questions. Can you repeat the part about the difference between diabetic ulcer and pressure ulcer again?
Sure. Some key things on diabetic. Diabetic is always going to be located on the plantar aspect of the foot, mostly, over the metatarsal heads, under the heel. Also, you could have it on the areas on the foot subject to rubbing footwear, possibly. They also have a sensation issue going on, so you have a diabetic with peripheral neuropathy, so that would be another thing that would be different. That would be a standout. So in diabetic, you'd have a diagnosis of diabetes and peripheral neuropathy in order to have a diabetic foot ulcer. Pressure, if we move back to pressure, that's pressure to a bony prominent site, or it could be caused by a medical device that broke down the skin. So, I mean, and then this, of course, we would use the staging system to stage how bad the destruction is of the skin. That's the best thing I could do. Now, I believe on my cheat sheet I have diabetic ulcers in the column for you as well to help you.
Great. Thanks, Nancy. How can you tell if purple discoloration is hematoma and not a bruise?
You have to go back to history. And that's, that's using your assessment skills, interviewing the patient family. Hey, what happened? What happened to result into this? And hopefully you can figure that out. Mm-hmm.
Great, thank you. When a stage 3 pressure ulcer is closed but still non-blanchable, how do we measure it?
A stage 3 pressure ulcer is closed. Is that what they said?
Yeah, but usually stage 3 is not intact, correct?
Yeah, correct. Stage 3 would have to be open and active, and the destruction would have to be, epidermis gone, dermis gone. You have to be in the sub-Q in order to have a stage 3.
Okay.
Mm-hmm.
What product do you recommend for stage 1 pressure ulcer?
Stage 1 pressure ulcer? It all depends on kind of where it is, but here's just a list of things off the top of my head. You could use a hydrocolloid. Okay, you could use a transparent dressing. I'm talking generically. But, you can always talk to Shield Healthcare on this, and they can kind of help navigate you on the specific brand product. But transparent, hydrocolloid, there's even, moisture barriers that can be placed on the skin, petroleum or zinc oxide based, offloading devices, wedges, just to give you a few. Some folks like to skin prep these. Some want to be more aggressive and cover it. Some may even choose a foam dressing because a foam can be in place for 7 days, and thicknesses of foam have changed in life. Some are thin, some are really thick. You might need that for extra padding. So those are just a few off the top of my head. I definitely, Shields have that cheat sheet that can kind of help you navigate. I'd make sure I get my hands on that too. That'd be really helpful for you.
Great. Thank you, Nancy. And I apologize. Again, there's so many questions that we just have time for a couple more.
Okay.
When IAD is bleeding and the zinc will not stay, should I just try to remove moisture and air the IAD out? Well,
we got to figure out what causes the bleeding. The bleeding is not a good behavior. Bleeding will eventually stop. I would make sure that you figure out what the source of the bleeding, bleeding could be caused by bioburden. Figure out what's going on, why this thing is bleeding. Maybe it was just the rustling of the sheets or the patient transfer. I don't know, but figure out the source of that. And let's just say it just bled because somebody just rubbed up against it, or the side rail rubbed up against it and it stopped. Well, then I would make sure that you clean the area good to get rid of all the excess blood or any kind of crusting. And once the bleeding stops, then go ahead and put some a nice moisture barrier on the site. But don't feel like you have to do it when it's bleeding. Figure out what caused it and get this thing resolved before putting product on it. Mm-hmm.
Great, thank you. How can I know if it's arterial ulcer or venous ulcer from the first look of the ulcer?
Okay, so here's the key. Remember, location is key. Remember I said A for ankle? Okay, or A for arterial. So think of A, and arterial ulcers are generally ankle down. So it's ankle down to the toes. So it's the foot. Okay, venous are going to hang out mid-calf to ankle. So venous is going to be mid-calf to ankle. Also, it'll tend to be medial. Those are key signs on location. But again, in order to distinguish for sure 100% if you're dealing with arterial, venous, sometimes you can even have mixed, and I didn't even want to bring that up in this webinar, but you can even have mixed. You've got to do an ABI. An ABI will tell you exactly what you have going on.
Great. I think we have time for one more question, and I want to go over how to get the CE credits for those of the...
oh, yeah. Okay.
When a pressure ulcer is closed, how do you measure it?
When a pressure ulcer is closed, so that means I'm assuming it healed. Well, if it's healed, and you're sure it's healed, well, then there's nothing to measure because there's nothing open and active. It's probably healed. Now, let's just say it just healed today, you could measure the site of the scarred area that you see, and you can say that it's 100% epithelialized over. The site measures 5 by 4, and you could do that, but once it's closed and healed and deemed as healed in the books, there's nothing to continue to measure.
Great. Thank you, Nancy. Do you want to go over to the next slide and let people know how they can get the CE credits?
Yeah, that sounds good, and I'm glad Eric was able to, put in some of your questions today. I know we didn't get to all of them. I will read the chat box if you guys ask questions, and I will try to see if I can perhaps maybe answer some of those, or I can just email you directly. That sounds like a good idea, huh, Eric?
Yeah, that sounds perfect. Thank you.
All right, now here's the scoop if you guys want continuing education credit, because you deserve 1 credit because being with us today. So here we go. For individuals that registered online, you will receive an email from my company, which is WCEI, within 5 business days. So I want you to check your spam. Sometimes we go into spam. And then once you open up the email, it'll look something like this on the screen. You need to click the link. You do an evaluation of the webinar that we did today. And then once you submit that in, then we are going to email you your certificate, and it'll be on email. Now, there are some groups that I know that are sitting, on the audience today. So for individuals who did not pre-register, or any of the groups that are coming from agencies, you can download the sign-in sheet, and you can only just use 1 sheet per group is good enough. And there's also an evaluation form, and you can email those or fax and email those to marketing@shieldhealthcare.com. Once they get that, both documents, they'll account for that, and then they're going to make sure that the CEs are sent to you within 3 to 5 business days. This version is recorded from when we started, so if you have any friends or staff members that would like to see it, it will be available on my website, wcei.net, and it will be for free, and your friends and your staff can also get a free CE by going on my website. So that is the scoop on that. Hopefully I was clear.
Great. Thank you, Nancy. I'd like to thank everybody who attended this webinar. This was really, really informative, Nancy. Thank you so much for all this great information. Again, this will be posted on our community page this afternoon. And if you have any questions, anything at all, marketing@shieldhealthcare.com. I know that's a lot of information regarding the CE credits. You can also check out our community page, shieldhealthcare.com/community. Go under the healthcare professional section, and it also tells you how you can get the CE credits. So again, thank you so much for your great presentation. Thank you, attendees, and we look forward to more from you. We have another WCEI webinar in January, so look out for that. That's going to be on ostomy, so we'll send out that information, and we'll go from there. So thank you, everybody.